Right.
Thanks for coming, everybody. We'll get started. So for those of you that don't know Dr. Hull, he's an endocrinologist here at the St. John Regional Hospital, and actually from Northern Ireland.
You don't need to say all of that, Heather.
No? Okay.
Pick bits of it if you want.
Moved to St. John in 2011 and has been a valuable part of our staff here and is very involved with different diabetes task groups and initiatives. Was there anything else you wanted to highlight?
No. Okay. You asked for it, so you know.
Yeah, good. Well, I'll hand it over to you.
And we've got 55 minutes or something like that. You have to be out of here by 1?
Yes, the other group's back at 1.
Okay.
So 55 minutes or so.
So thank you all for coming. It's always I always like to talk about diabetes, and many of you I have talked about diabetes with. So normally we put up disclosures and stuff like that, but I haven't done that. But just to say, I am part of the Dissemination and Implementation Committee for the Diabetes Canada Guidelines. I am for this one and was for 2013. So that may be a bias for those of you who are into that sort of stuff. I have helped with updating some of the tools on the website. So again, maybe that gives me insight, or maybe it makes me biased and too blinkered. I also get money for speaking about diabetes. I don't think I'm getting any today, and I'm not asking for any, but all the diabetes pharmaceutical companies have given me money. So if you want to factor that in, am I biased or not? But they've all given me money, so I'm equally biased or not biased. I just wanted to disclose those things. Sorry? Okay. So we're going to basically talk about the 2018 guidelines. It's actually almost a year since they were published last April. This is the essentials slide set, which is straight off the website. We're not going to go through the whole slide set because it's 75. We've picked somewhere around 30 slides. I don't want to talk much, so please feel free to interrupt me with your questions. I know some of you know a lot about this. Those of you who I don't know probably know a lot about it as well. So I would rather clarify your uncertainties and hear your questions than give you lots of stuff you already know. So stop me if you know it all. Is that fair? And just interrupt and ask questions. All right? That's okay for an introduction? So the learning objectives, and this deck focuses a lot on the changes. So that assumes you know the 2013 guidelines with great familiarity, of course, but I will try to highlight the changes for you. I don't know if I'm going to focus, we naturally will focus a little bit on the rationale and try and apply the guidelines. So any clinical dilemmas you have, scenarios, stuff like that. So how many of you use the website or the app on a daily basis? Embarrass you? Weekly basis? Monthly basis? Who's ever looked at the Diabetes Canada guidelines? Okay, so a few of you. So they're the best diabetes guideline website in the world. And I'm not Canadian, so I can say that without any bias, although I've written some of the guides. But anyway, you can interpret that. So there is an app which you can get on either Android or Apple. So that's helpful decision guides. So I do encourage you to really look at the tools that are out there. An important note for those, and I know pharmacists know all about this, so the guidelines were kind of finalized towards the end of 2017. So any new drugs for diabetes that were launched, for example, Ozempic in early 2018, that's the reason they're not in the guidelines, if anybody was wondering about that, or Soliqua or Zoltify, some of the newer things that have come out. These guidelines are formally updated every 5 years, but there's interim updates whenever there's groundbreaking things. So I've heard on the grapevine we will have a number of updates this year, perhaps in light of the DECLARE study with Forxiga in November. When the Trulicity study Rewind is presented in the fall, we may get an update in 2020, and so on and so on. So there may be a couple of updates, so keep your eyes open for those. That's what the kind of entry page on the website looks like for those of you who haven't seen it before. It is really good. And there's a little plug for the app. And basically, because I've talked today, Diabetes Canada get an email from me saying I've presented the guidelines, so they keep a log nationally of how many people are being updated on the guidelines. Okay. So a key message for all of this is it's not cookery. You're not making the same recipe for every patient. We've got to individualize. And the same treatments won't be implemented for every patient for various reasons, and clinical medicine is complex, and we're focusing on the patient's needs, their lifestyle, their quality of life, their expectations, their willingness to adhere to treatments, and so on. All of that stuff we all struggle with. So we're kind of into the meat of it. There's different sections, and Heather and I talked a little bit about which to include. We left out diet and exercise, screening for complications, and foot care. And I left out a bit about driving. Does anybody really want to hear about those things? No? You're okay. All right. And as I go through each section, we should have a list of the sections in the middle of this talk, but there's screening, and then I think we go into the ABCD of how to treat diabetes, cardiovascular protective drugs, and that's pretty much the meat of the talk. So does anybody want to know about screening, or will we skip off? Are you involved in screening? Do you need to know this? You're all hospital based? And can everybody hear me who's on Skype? Can I speak back to it?
Yep.
Yep, everybody's good. Okay.
Yeah, it's mostly inpatient pharmacists. We do have some work in primary care and ambulatory care.
Yes.
Well, sure, will I go through this briefly? Is that okay?
Sure.
All right, if you have any questions. So this is currently the guideline. So if you're focusing on adults might have type 2 diabetes. So if you're over, and this a lot would apply maybe to family doctors, community pharmacists. I don't have to do a lot of this in practice. So for an individual over 40 years of age, you would screen every 3 years, or in individuals that you otherwise consider at high risk for various clinical reasons. And you can use a risk calculator. On the website, there is a thing called CanRisk, which you can use to try to work out if somebody's at high risk or not. You can have the option to screen more frequently than every 3 years, perhaps every 6 to 12 months, for people that have additional risk factors for diabetes or they're high risk on a risk calculator. In my clinical practice, where I see that most is people we see with gestational diabetes or diabetes in pregnancy, as we now call it. So when we're discharging somebody after their pregnancy, we would kind of advise they go every 12 months for some form of glucose testing. And we probably leave that to the discretion of the family doctor, whether it's an A1C, a fasting glucose, a random glucose. You'll see that a little bit later. Any questions about that? Okay, so there's 4 categories here. This is new. In previous guideline, there were 3 categories, so there's been an additional one built in. And this guidance is based on a lot of epidemiological studies, so it's open for a little bit of argument. But on the left is what's considered normal, or more appropriately, I could say, not considered to be at risk of diabetes complications. So diabetes is not an on-off diagnosis. It's not you reach a certain point and you suddenly change your characteristics. It's like a continuous variable, the same as blood pressure, cholesterol. It's not have diabetes, don't have diabetes. Unfortunately, we tend to think about it like that because we don't say you're a hypertensive or you're a hypercholesterolemic. We say you've got high blood pressure or you've got that high cholesterol. We should say you are a person with diabetes, or you're a person with higher than normal blood glucose. So subtle, you can get my subtle point there. But this is where we don't consider there's really any risk. So fasting less than 5.6 and or A1C less than 5.5. So normal, you continue to screen as above. At the other end of the spectrum is where you would be diagnosed with diabetes. So your fasting plasma glucose is greater than 7, and or your A1C is greater than 6.5. We'll talk about this a little bit more detail. This is the new category where you're at increased risk of complications, be it cardiovascular or microvascular, but you're not formally diagnosed with either impaired glucose tolerance or diabetes, but epidemiological studies have shown us these levels are associated with risk. There is in the small print of it a race or qualification as well. So people from South Asian particularly, but also Southeastern Asian, the cutoffs are different. So the risk is at lower levels, I should highlight that. But so the fasting plasma glucose 5.6 to 6, A1C 5.5 to 5.9. So that's at risk, rescreen more often. Then this is the one that was in the last guidelines that you may be more familiar with. So fasting plasma glucose is elevated but not in the diabetes range, and A1C is 6 to 6.4, so not 6.5, not diabetes range. So that's sometimes called impaired fasting glucose or impaired glucose tolerance or prediabetes or dysglycemia. There's various terms. So the progression to the fourth category is much higher when you're in the third category. The progression to the third is higher when you're in the second. But the progression from 3 to 4 is the highest risk, so you'd rescreen more often. Questions? Okay. Yep.
Curiosity. Patients as a favorite list for
Right.
goes on a great diet and it's all healthy and doesn't have high.
Yep. That's a good question. Formally, no, but I would counsel the patient that you've displayed risk. So I think you might categorize them in one of the other risk categories. You could say they're normal, but they're not. They're never quite normal because they've got into that scenario. Unless you had an acute illness or steroid treatment or something that was really influencing the acute situation. But yeah, I mean, clearly people can revert back to normal. I've seen A1Cs of 11% go back to normal. And there's published studies with very aggressive lifestyle change or bariatric surgery can induce a remission of diabetes. Being in remission might be a good way to think about it. So it could come back, but if you stick to the lifestyle, you're lowering your risk of it coming back. Does that help answer it? Okay.
And the question actually,
right.
when it was an insurance,
Yeah.
and what is the
Yeah, and that's a tricky one, and I've come across that before, and all I've done in that scenario is provided my medical opinion, and the insurance companies probably do it not in favor of the person applying for the insurance because they're trying to save money. But I feel like all I can do is give my medical opinion on it. I'm happy probably to say a person's normal, but they did have diabetes at one stage. I don't know. So this is a little bit more detail about the fourth category in the last slide. So fasting plasma glucose greater than 7. So you have to be sure that they're fasting no caloric intake for at least 8 hours. So water's okay. It's a bit unkind to make people not drink water during that, I think. Or A1C is greater than 6.5%, and there's qualification about the standard of the test, but most major hospitals have a good enough test. We don't do the oral glucose tolerance test very much anymore, but a 2R greater than 11.1 or any random glucose greater than 11.1. And I don't know I think it says it in the next, so if someone has symptoms of diabetes plus one of these, we tend to say you have diabetes. In the absence of symptoms, we usually want another confirmatory test because certain acute things, stress, illness, might have influenced it. And for many reasons, including insurance reasons, we don't want to classify somebody as having diabetes if we haven't confirmed it. And I think that's about all I want to say about that. Sometimes if the two tests are discordant, you might do a third one again. And then that kind of summarizes, again, a little bit of what we've seen before. No, it doesn't. Sorry, that's the pre-diabetes slide. So but it's been on the slide, so it's 6.1 to 6.9. If your 2R on a 75 is 7.8 to 11, so 11.1 and above is diabetes, less than 7.8 is normal. and the A1C 66.4. That's a tool on the website you can use for this, which will guide you through the process. So that's that screening section. Any questions? Clarification? All right. So approach to management. So this is kind of the main part of the session, I guess. So this is the framework that's kind of been used as an aid memoir to help us. And in the 2013 guidelines, it was just one S on the end. We've included 2 extra ones. As I say, we're actually skipping the E and the 3 S's for today, but just for your information, screening, smoking cessation are important, and self-management, stress, depression, social barriers to care, etc., are all part of our framework for management. But we're going to focus on the A, B, C, D. So A to begin with. So any comments on A1C targets? Questions or comments? Okay. Should everybody be 7? Okay. What percentage of people should be 7? That's the current figure. The latest available figure in Canada is that 50% are less than 7. Is that right? The answer is who knows. But that's quite often when you hear people, the kind of prevailing attitude is everybody should be 7 or less, and if you're not, something's wrong. Either the healthcare provider is not doing their job or the patient's not doing their job. And it tends to be people who don't know anything about diabetes say stuff like that, or have never seen a patient with diabetes. Because point number 1 is not everybody should be at 7. There's no evidence in type 2 diabetes for 7%. I don't have time to go through that, but I think the last time I did your grand round, I went through that in more detail. For those of you who were here, 7 is a reasonable, pragmatic target, having said that, and I think most people should be 7. But the exact percentage, we don't really know, because everybody's different, and our target should be individualized. The second point I'd like to make is it's difficult to get to 7. And for people who've never seen a patient with diabetes, they tend to think it's easy to get to 7, and they judge people, either their healthcare provider for doing a bad job or the patient for doing a bad job if they're not at 7. I don't think in medicine or pharmacy, for that matter, we should practice judgmentalism, or we should be supportive. And some people like a judgmental approach, but I haven't found many of them. You find anybody like that? Likes to be beaten up for not being 7%. So the guidelines basically tell us most people, type 1, there is direct evidence that 7 is better. I'd be a little bit more concrete about that target, but it's even harder to get to 7 in somebody with type 1 diabetes than it is in type 2. Earlier in type 2, it's easier to get to 7. Later in type 2, it's harder to get to 7. So we have to factor that in. We can aim for better than 7. Very little direct evidence for this. There is some from the advanced study from 11 years ago that nephropathy is reduced further if you go to 6.5%, particularly with gliclazide, for all the gliclazide haters in the pharmaceutical industry. So I would aim for 6.5 in selected patients. I actually aim for 6 or 5.5 in selected patients without any real evidence base for that. But theoretically it's good, and if you can do it easily, why not? Let's put people into remission if we can. This is the get out clause and the conditions in which you would allow them to get out. This is a shorter list than the 2013 guidelines, because I think a lot of people could remember it. But they're the predictable ones, perhaps. People that are functionally dependent, where that might influence diabetes treatment. Where through trying to treat aggressively, you're getting difficulty with hypoglycemia or hypoglycemia unawareness. If somebody's got a limited life expectancy, why bother for aggressive treatment? You might want to control symptoms, but the complication reduction is over 5 years for some cardiovascular reduction, longer for some others, so you're not going to achieve anything by treating aggressively. And the frail elderly, dementia is a point I need to raise. Many of you might be aware of the Diabetes Care Program of Nova Scotia guidelines, which are very relaxed. allowing A1C up to 12% and blood sugar of 20, which I think is appropriate and out of keeping with national guidelines, because we share practice across Atlantic Canada. Some of that is filtering into other provinces, and we should guard against that. Their guidelines are reserved for the very frail elderly, the 6 or 7 on the clinical frailty score. So those would be people who would be very frail, dependent in a nursing home, no ADL ability in a very high care environment. But unfortunately, the old rumour mill practice of medicine, Nova Scotia don't mind 12% if you're over 65, is somehow that gets extrapolated to. And so everybody, I see you're 65, I'm going to stop all your diabetes medication, is what we've seen happen. So they get admitted with falls, acute kidney injury, delirium, fractures, etc., etc. So there has to be a balance. And that's where this kind of comes in. Avoid the very high A1Cs. You will get symptoms. If they're a frail, demented patient, you may not notice those symptoms, and they may develop acute complications, which we see in 4C North and other wards all the time. Any questions about A1C? Okay. End of life, don't even measure it. But there's a guide on the website as well.
This now?
And then it's cut off at the top, but this is a flow.
I have a question.
Hello?
Yes.
Yeah, go ahead.
Regarding the support, if the patient doesn't have that much support, do we still keep him between 7 and 8, or?
Yeah, that's a good. It depends on the exact scenario, I guess, and that's where the art of medicine comes in. So there's no right and wrong answer, but it depends what they can manage. But according to the guidelines, you're allowed to go to 8.5% if allowed is the right word. And we need to look at the pattern of glucose, of course. If they're on insulin and you're worried about their ability to self-manage, you not just look at the A1C, but look at the pattern of blood sugars and troubleshoot that. I would personally go up to 9% on quite a number of people. Rather than 8.5 in individual circumstances. Above 9, you start to run into the acute complications potentially, and even chronic complications if they've got a good life expectancy, despite their frailty or limitation on management. Does that help?
Yeah, thank you.
Okay. Any other questions on Skype? We don't want to miss you. Okay. So this flow chart is very useful, I think, was also in the 2013 guidelines. It's been a little subtly changed. This bit is about the same, except it's termed behavior interventions. So they changed the terminology a little bit. And there's self-management is in the small print there. So they changed it from 8.5% to 1.5% above target. So you can be less than 1.5 or greater than 1.5. Which I think was a subtle, important thing, because if you're saying it's above 8 or below 8.5, you're implying everybody should be 7, whereas we're saying everybody shouldn't be 7, so I think this is important. I generally start metformin immediately, no matter what, rather than the plus or minus metformin. But if you're above 1.5, if you're more than 1.5 above target, and I must admit I'm cautious doing this, but I do it in selected patients. Maybe I should do it in more. We have the go-ahead to start a second agent concurrently. Across Canada, the majority of people, that would be probably a DPP-4 inhibitor, with an SU still second. SGLT2 prescribing figures are going up, as many of you are aware. So that would be your broad options for the second line. If you're less than 1.5% above target, you probably can continue monotherapy with metformin or another agent if they're intolerant, and work on lifestyle. The symptomatic ones that you're maybe thinking they're type 1 in disguise, or you can induce a remission by using insulin, and you can do insulin safely. I would do a lot of this in younger people, particularly where I start them on insulin and metformin right at the get-go, and then withdraw the insulin gradually as their pancreatic function improves. This box is since 2015, since the EMPA-REG study was published. This is the number one question we should ask ourselves when we see a patient with type 2 diabetes. Never mind the stuff at the top. In a way, if I'd been in control of this flow chart, I would have moved that up a bit higher. In fact, right at the top. So that's the main question. So if it's a yes, we now have more than 3 drugs that have evidence that because of the cutoff for these guidelines, there's only 3 on the chart. The ones that'll join at some point are going to be Ozempic or semaglutide, Trulicity, dulaglutide, and Farxiga or dapagliflozin. Hopefully they'll join fairly soon. So the level of evidence is slightly different for the 3 that are there. Is it fair to canagliflozin to be that level of evidence? I might argue it should have been a higher level. There's the amputation issue, which we can talk about. There's a new European American Diabetes Association's joint guidelines, which does a better job at helping you decide between SGLT2 and GLP-1. And I think that will be when the Diabetes Canada guideline is updated sometime this year. I think that will be incorporated. But basically that revolves around, it's emerging, and many of you are probably aware of this, GLP-1s seem to be better at reducing ischemic events, so a heart attack or a stroke. SGLT2s will do that, but less so, whereas SGLT2s are better than GLP-1s at reducing the failures, so the heart failure, the kidney failure. EMPA or Jardiance showed a substantial early mortality benefit in the EMPA-REG study. That has not really been seen as strongly in the CANVAS study or the DECLARE study. So people are starting to, although we think Jardiance reduces cardiovascular mortality, and a study has shown it, and it's Health Canada approved for reduction of cardiovascular mortality, and even CADTH have said it reduces cardiovascular mortality, and rumour has it the NBPDP are going to include it for the cardiovascular indication very soon. But still, there's a little bit of skepticism being brought to bear on do they reduce mortality because of what the CANVAS and the DECLARE study showed. So just to put that in. So when I look at a patient now, I'm saying, are they predominantly an ischemic patient? And I'll go for GLP-1. That would mean they don't have diastolic dysfunction on their echo. They don't have microalbuminuria. They don't have any kidney disease. They don't have significant hypertension. They've just had an MI. They've had a stroke, and that's it. Whereas if I see somebody with delayed relaxation, diastolic dysfunction features in echo, a bit of microalbuminuria, a bit of chronic kidney disease, difficult to control hypertension, normal LV systolic function, I'm thinking more of an SGLT2. If they've got a bit of both, which they can have, then I can go either way, and I might then be saying, well, do they need more glucose lowering or more weight loss? Because GLP-1s, particularly Ozempic, are more efficacious for those things. Does that help, or any questions? But that's kind of where we are on our 2018 guidelines. So question number 1, do they have clinical cardiovascular disease? We could get into the definition of that, but it basically means they've had a clinical event. Not really that they've had subtle clinical evidence of atherosclerosis, but they've had a stroke, an MI, a significant peripheral arterial event, and then you must start one of these. So I'm doing this all the time. For example, I was teaching medical students this morning. The pretend patient we had with a respiratory illness that he actually had a coronary stent 2 years ago, type 2 diabetes, he's on metformin and gliclazide. So I wrote Jardiance 10 milligrams down on a bit of paper and said, take that to your family doctor and have a discussion why you're not on it. So there's a lot of people out there who aren't getting it. He had private drug coverage. Why he wasn't on it, I don't know. So if it's a no, then according to our 2018 guidelines, we're looking more at what the glucose is. I should say I don't really care what the glucose is anymore, to be very provocative. Or it's down my list of priorities. It's always been down my list of priorities, but even more so with our cardiovascular outcome trials. So when I start a cardiovascular protective medication, I don't want to know what the A1C is. I do, because I want to alter the other treatment potentially. But I'm not starting the cardiovascular protective drug to lower A1C. Does that make sense? Mm-hmm. Whereas if they don't have clinical cardiovascular disease, I'm looking more at what their glucose target is and using the factors on the next page to help me decide. Now with the DECLARE study, this needs updated because we now have some evidence if you don't have clinical cardiovascular disease for benefit of dapagliflozin. And when the REWIND study is presented, which I think is going to be presented in September at the European meeting, we have primary prevention evidence with Trulicity. So that's why the guidelines need to be updated soon or later this year. But the factors, this is very similar to 2013 with a couple of differences. The factors are put a little bit more succinctly on that side at the bottom left panel, and the non-glucose lowering, the non-hypoglycemia causing drugs, I should say, are elevated above sulfonylureas. We could debate, is that appropriate? I think it probably is, but the cost and the coverage and the cost of the taxpayer or your private plan are considerations with that. It doesn't mean SUs are bad, in my mind. It means these are better. So you're basically individualizing based on a lot of characteristics, and this is where it gets difficult, but we're really trying to avoid hypoglycemia and weight gain in the majority of our patients if we can. So that involves using generally one of these three classes. Because of the lack of cardiovascular protection with DPP-4s, although they're still the most widely prescribed second line in Canada, they're at least leveling off or decreasing in the New Start data, and I think eventually they'll decline. The right studies haven't been done necessarily with these drugs. From the Carmelina study, Tradjenta might have become my favorite DPP-4. Prescribing in New Brunswick is basically 100% sitagliptin or Januvia. I think I'm a little lone voice of Tradjenta, but if you haven't read the Carmelina study, I recommend it. It was presented in September at the European meeting. And then there's all these factors over here. Any questions? Yep, Luke.
We obviously have formulary issues. Is that impacting the patients you're seeing in clinic? Like, did you get referrals?
Yep. SGLT2 problems we can surmount because all the companies give us copious amounts of samples. They deliver them once a week, basically, to us. We have pooled our samples in the endocrinology division, so we give out samples all the time. I have patients come up. So if somebody has a cardiovascular indication, I will start. It's not a barrier to me starting it, but it's more work. So we usually give them a month's supply to see if they tolerate it, and then my secretary and them get a 3-month supply set up thereafter. So it's just free drug. Or the patient assistance program we can use if people are very socially disadvantaged. But again, that's another step of bureaucracy, so I tend to just give samples out. For GLP-1s, we don't get as much drug, so that's a barrier where I want to use that. I mean, I'm compromising my comments earlier. I'd rather use that for greater glucose weight loss efficacy or for anti-ischemic effect. I'm being limited in what I can use. I'm hoping Novo Nordisk will do a deal with the province to make Victoza cheap because of the success of Ozempic, but that may never happen. Does that make sense? Yeah.
Yeah, we always see quite.
And we've lobbied the government. I've told patients to speak to their MLA. I've told patients to sue the government because we have a medication that reduces cardiovascular mortality. It reduces hospitalization for heart failure by substantial amounts. It reduces progression to dialysis by substantial amounts. But because we organize our healthcare spending into budgets and different silos, we're actually wasting the province's money. Dialysis is $70,000 a year. We could save, by spending $900 a year, we could save $70,000 a year. You know, well, we're going to save half of whatever. I haven't worked out how many patients our new dialysis starts in New Brunswick per year, and we would need to treat double that number with $900 a year. But I think cost savings are probably immense. $1,000 a night in the hospital for hospitalization for heart failure. It's, in the back of an envelope you could probably work out it's going to save the province money, but the health department can't organise themselves. Anybody from the health department here today? Anyway. Any other questions? Okay, so this is I'm not going to go through this table in detail, but this is a big detailed thing on the website. You can, if you want to look at it and talk to me later. But the change this time, it elevates the 3 classes that are being promoted more actively to the top, whereas last time it was in alphabetical order. And I like the way it's set out in terms of cardiovascular benefit is put first, hypoglycemia, weight, A1C lowering. So in a way, A1C is the least important thing, as I mentioned earlier, and then other considerations and cost. So I think it's a nice way to summarize the issues, the practical considerations. So now if anybody has any questions about any of the drugs that are up there. Nope. All right. We can come back, and I think that's basically just, you might end up using all of them, so you don't need to really worry too much about which one. So we've talked about you might want to start both drugs at the beginning. A lot of the patients I see are on 3 orals and insulin, or 3 orals plus a GLP-1 plus insulin. Despite what I've said about A1C, I do try to control it. Don't get the wrong message. It's just down my list of priorities. Controlling A1C is more tightly related to microvascular complication reduction. So we can keep them alive without a heart attack. We've still got to prevent their microvascular complications occurring and not neglect that. And we tend to have therapeutic inertia. You end up 5 years later, you make another treatment decision. It's within 3 to 6 months. Now, there's often an excuse, well, I was on a cruise, whatever, I had an acute illness, my A1C is not representative, I was too busy, I'll make better effort next time. So it can stretch to a year or 2 before you know it, but 3, 4, 5 years without changing anything is a little bit negligent. And Heather did ask me to talk a little bit more about my experience of the newer insulins. So this is I think this is a nice table on the website summarizing what you all know, probably being pharmacists, I hope. You know better than I do, hopefully. But anybody want to ask about, I've used a lot of the new insulins, I can share my experience, but any particular questions? There's the new GLP-1 long-acting fixed injection. I haven't actually used much yet. So I'm still struggling to work out which patients I'm going to use them in.
I have one question. With the Traceba,
yep.
Where the duration is so long,
yeah.
Do you see a build-up effect after a couple of days? So would you start something lower and then increase?
No is the answer, but my question is, I've asked this to Novo Nordisk and across the country when I've been at meetings and nobody knows the answer is dialysis. And I think there's little experience. I think they've done some dynamic pharmacokinetic studies in renal impairment, but not many in dialysis that shows there's not much dose accumulation. But I guess I worry a little bit, with dialysis, you get this dynamic of insulin clearance changes day on, day off dialysis, and your resistance sensitivity alters a little bit day on, day off. So I've been a little reluctant to use it in dialysis.
Question?
Yep.
Yes, regarding now the long-acting Lantus and versus Basaglar, I want you to, if you can share your experience, if you find anything regarding Basaglar versus Lantus. This one question. Second question regarding any hypoglycemia differences.
Okay, between Basaglar and Lantus, or between the other insulins?
Yeah, Basaglar and Lantus, because now there is a trend to switch to Basaglar. I can see it. So if there is any difference from your experience?
I've noticed no difference between the two. And I I've been obviously Basaglar is produced by Lilly, reputable insulin company, slightly different process, but it's biosimilar. I'm content with the process and regulation behind that. Clinically, I've noticed no difference. They had to. It was a clinical trial program before it was launched. FDA approved, Health Canada approved. I don't know if you've noticed differences or anybody else has noticed differences. But to me, it's a no-brainer because it's cheaper. I would rather the province saves money on Basaglar, and I was a bit surprised in a way they went for Tresiba, although I like it because there's times I want to use it. But I'd rather have. Why did they not approve Jardiance before Tresiba? Jardiance has a substantial outcome benefit. Tresiba has no outcome benefit proven compared with other insulins. Theoretically better, but why do they? What's the rationale with the decision making? Does that help?
Yeah. Thank you.
Hypoglycemia, I've also noticed no difference.
Yeah, thank you so much.
But definitely, my preference for insulin is Toujeo or Tresiba. Between those two,
Tresiba?
Yeah, I probably prefer Tresiba, but for certain individual patients, the relative advantages of Tresiba aren't really needed. So both Toujeo and Tresiba have lower hypoglycemia risk than Lantus, because that was the standard insulin, the best insulin at the time they were compared with. There's one study, the BRIGHT study, comparing Toujeo with Tresiba, but it was sponsored by Sanofi. The design was a little bit unusual. It did show less hypoglycemia in the titration period with Toujeo, in favor of Toujeo, but they only compared with U100 Tresiba, not U200, which is an important distinction, I think. Novo Nordisk have an ongoing study with their design slightly odd, comparing Tresiba with Toujeo, using both U100, U200. So I think we need to see that before we can say hypoglycemia rates are different. Toujeo is cheaper, which is an advantage. Tresiba is longer acting and more flexible for people with shifts, travel, forgetfulness. I think Tresiba's got an advantage. The 160 units in the pen, the longer time out of the fridge, are relative advantages, but it's 20% more expensive than Toujeo. Basaglar is 20% cheaper, as far as I'm aware. So is it worth paying that extra for Tresiba? Not for everybody. I think you have to have a reason to go for Tresiba. You even have to have a reason to go for Toujeo. But my bottom line is we want to avoid hypoglycemia at all costs for lots of reasons. So why would I go with Lantus or Basaglar other than to save money? I think it was immoral, if that's not too strong a word, to use NPH instead of Basaglar or Lantus. I just lied on the NBPDP forms and said they had major hypoglycemia because I wasn't going to be responsible for prescribing something that was going to cause hypoglycemia. Yeah.
So I'm trying to switch a patient from Lantus to Tresiba.
Right.
And the Diabetes Canada guideline says to go unit per unit.
Yeah.
But it also says it can be controlled with lower units of insulin. So the same success rate with the lower unit. But that's my question,
so Lantus to Toujeo, you're saying?
Toujeo is not covered, so we are moving from Lantus to
Tresiba. Okay. So yeah, so if you're on NPH or twice daily other long acting, you reduce by 20%. If you're on once daily non-NPH basal, it's one unit per unit. If you're going Lantus to Toujeo, the initial studies actually suggested you need 11% more units of Toujeo. The real world studies have shown you don't, but you maybe do. Tresiba, yeah, you may need less.
Less.
Yeah.
So
But I still go 1/1. But it depends. If they're really tightly controlled, I might reduce it slightly. Most people aren't tightly controlled, so I wouldn't necessarily reduce. Does that help?
yes.
Okay. Any other questions?
We have about 10 minutes,
10 minutes.
for blood pressure.
Yeah, okay, we better move on. And Fiasp, I've used a bit of, arguably that's the best rapid acting insulin, but there's less advantages. Flexibility is the main, unpredictable eating, but it's more expensive, so I probably used less of it or see less need to use it than Tresiba Toujeo. Again, I would concentrate the money in other areas. I'll skip through these, but you're probably aware of these prescription guides. I should use them more, but in a way they're probably designed for people who don't know much about insulin. But it gives you a guide to go through all the different things you need to think about. Are you all familiar with that? Probably our community pharmacy should use it more. It's very good, I think. And there's titration guides. Use of drugs in renal impairment, I guess, do you want to talk about that? Metformin is always thrown out there. Should we use SGLT2s in kidney impairment?
I have a question.
Yeah.
Yes, actually, there is the debate always around metformin and renal impairment.
Yeah.
And also, especially the cutoff to continue in CKD, and the other point also with metformin with acute kidney injury as well.
Yep.
There's a tutor for acute kidney. Maybe it's clear, but for CKD, I can see there is variation among. Yeah.
I mean, it's based on very little evidence, and it's based on the worry about lactic acidosis, which was probably too focused on. And you probably all know metformin doesn't damage the kidneys. I corrected another patient yesterday about that. But I have a long time practiced what is on this slide. Get to 45, I reduce the dose. 30, I stop it. There's an acute kidney injury, acute illness. It's a sick day, SADMANS, which is a slide later. I would stop it in acute illness, restart it when they've recovered. Does that help?
Yeah, just if there's any report that metformin, not the risk of lactic acidosis, but if metformin can induce renal impairment as well, for example, in patient with in post-surgery or in patient in dehydration stage, can induce.
No, I'm not aware of that, and that tends, unless you can show me an actual report with cause and effect, I would dispute that.
Okay, thank you.
But if you want to share that with me, I'm happy.
Sure, thank you.
Liraglutide changed to Victoza changed to 15 recently, which is really useful. SGLT2s we maybe get into at the end, but it's a struggle as you're approaching EGFR 30. It is a struggle to get people on it because of the initial decline before it stabilizes. Okay, so we better move on to B, blood pressure. There's not a lot of information on blood pressure and cholesterol because not a lot has changed recently. So this is basically, there's one slide on blood pressure. So both the threshold for treatment and the target are 130/80, which is always a bit odd. If you've got CKD or CVD, you're going for an ACE inhibitor and ARB. There's a big debate over which is better, ACE inhibitor or ARB. And there's two schools of thought. I traditionally was in the, if you've got CVD, you should be on an ACE inhibitor rather than an ARB. But some recent meta-analysis have made me think again. So you're probably not wrong if you use either. If you don't have CKD or CVD, to be honest, I would still go for an ACE or an ARB. But you have a more open choice. Second line should probably be a calcium channel blocker. Third line would be a thiazide-like. Think of two drug combinations if blood pressure is very high. I would add in as an endocrinologist, think about secondary causes of hypertension like THIO and hyperaldosteronism and so on. Cushing's. Combination therapies can help adherence. If you're starting ACE or ARB, check potassium creatinine 1 to 2 weeks later and periodically thereafter. Don't use don't use two drugs that block the RAS system. So we really no longer use ACE and ARB together, and direct renin inhibitors have kind of disappeared. Any questions about hypertension? Okay. So cholesterol, This again is relatively easy. I could simplify it by saying everybody with type 2 diabetes should be on a statin, and selected patients with type 1 diabetes should be on a statin. That's the simple guide. Again, I spend a lot of my time encouraging people to take their statins or starting if for some reason they've never been started. It's still a bit scary how many people looked after in primary care are in their 50s with type 2 diabetes and cardiovascular risk factors and are not on a statin. It's really scary. So if you've got cardiovascular disease, you have to be on one. If you're over 40, if you've got any microvascular complications, so that's nearly everybody with type 2 diabetes, hence my comment earlier. You get the odd person who's less than 40 with type 2 who doesn't have any of those three. I tend to start a statin anyway, or say you can start it if you want, but when they're 40, I start it definitely. The diabetes greater than 15 years and age greater than 30 basically caters for the type 1 group. Not really terribly evidence-based, but more expert opinion. If anybody with type 1 develops cardiovascular or microvascular, we tend to put them on a statin, even if they've had it less than 15 or they're under 30. And then if you've none of those, which is very few of the people I see, we use a risk calculator. The Canadian Cardiovascular Society can guide you on that. Childbearing statins are an issue. Acute illness may be another issue with that. Should you omit it in acute kidney injury? Conflicting evidence. And then D is drugs to protect the heart. So we'll talk a little bit more about ACEs or ARBs. We've talked about statins. We'll talk a little bit about aspirin. And I have talked as I've gone along about SGLT2s, GLP-1s. So we can deal a little bit more with that if you want. But so say you're not treating hypertension. They don't have CKD. They don't have microalbuminuria. They don't have coronary artery disease. Who else would you start an ACE or an ARB in? And this is mainly from the HOPE study and the Europa study and the PEACE study, which doesn't get mentioned on that, and the On Target. So generally, actually this is clinical cardio. Well, I thought some of these studies were primary prevention as well, to be honest. But clinical cardiovascular disease, and I think this should be this doesn't make clear in the slide, or greater than 55 with an additional risk factor who don't have clinical cardiovascular disease, or they've got microvascular complications, you would be considering an ACE or an ARB. And childbearing, acute illness, acute kidney injury, sick day, all come into this as well. That's a repeat of the last slide. Aspirin we only tend to use in secondary prevention. Selected cases in primary prevention if their risk score is high, possibly moderate. That's a change quite a while ago. I still see people filtering through who were started on aspirin 30 years ago, 20 years ago. Some primary care doctors are still starting it who maybe aren't aware of this. I've tended to stop it quite often or give patients the choice. So any questions about statins, cholesterol, drugs to protect the heart? And we're
probably end it there because we're just about at time.
Sure.
Probably have room for one more question if anybody has one.
I've covered probably most of what I wanted to cover anyway. So
well, it's a lot of material in there.
okay.
Go ahead, Carol.
I was just going to say, I'm just curious, if you have someone and their A1C is actually at target, and they have cardiovascular disease,
Yeah.
what are you doing in that situation? I know that's probably not that common.
Yeah. It's a very good question because it's hard to get coverage, even on private coverage for that. I would tend to, if they're on a sulfonylurea, stop it. And sometimes you can get private coverage with some of these people. They don't really look at the A1C target, but if you just tick the box that they're uncontrolled, you get away with it. But I would tend to stop the medication. But this is the bad thing about our system of drug coverage, of course, is that we have to let somebody get uncontrolled in order to get them on a medication they probably should be on anyway. Now, the way the studies were designed, the A1C was about 7. So if the A1C is 6.5, is there evidence of benefit? No, strictly speaking, but these drugs do not exert their cardiovascular and renal protection through lowering glucose. So why are we judging by the A1C in the first place? Would be my logic or answer to that. But it can be a matter of adapting the other therapy.
So would you add on? I guess it's metformin and a DPP-4. Would you be comfortable adding on? Or?
I would be comfortable adding on because that's not going to cause hypoglycemia. Yeah. But if we don't need the DPP-4, I would get rid of it.
Yeah. Okay. Thank you.
Yeah.
Thank you very much, Dr. Hall. Appreciate it. So for the sites on Skype, if you guys could either email me or fax me your attendance, the number of pharmacists and pharmacy students, that would be much appreciated. Thanks, everyone.
Thanks, Heather.
Thank you.
It was a bit rushed maybe, but it was.
It was good. I'm glad at the beginning we spent more time on the therapy. I think that was very necessary.
Maybe we should have skipped the screening bit where I could have gone quicker.
Thank you very much.
Did you send the sign-up